Hello everyone, my name is Nusrat Laporna and today we will be presenting our topic about mental health. We will begin by talking about why mental health is so prevalent in global public health, issues across regions with significant and disparities presented by Himani, parties involved with addressing the issues presented by Victoria, issues with the current policies around mental health presented by Janet, and lastly, 3 priority areas of action. So, why is mental health so prevalent in global public health? First, we must understand what the meaning behind mental health is. According to CDC, mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and make healthy choices. Mental disorders are health conditions that are characterized and alterations in thinking, mood, and or behavior that are associated with distress and or impaired functioning. Mental disorder contributes to a host of problems that may include disability, pain, or death. To see the global perspective of mental health, in 2017, mental and substance use disorders are around 1 in 7 people, which is about 15% of one or more mental or substance use disorder. Highest countries are Australia, New Zealand, and Iran. According to worldindata.org, this chart demonstrates that mental health disorders are common everywhere. Improving awareness, recognition, support, and treatment for this range of disorders should therefore be an essential focus for global health. This chart shows that about 970 million people worldwide have a mental and substance disorder in 2017. The largest number of population have anxiety disorder, which is about 4% of the population. Now let's talk about why mental health is important for overall health. Mental disorders are among the most common causes of disability. Globally, depression is one of the leading causes of disability. Suicide is the second leading cause of death amongst 15 to 29 years old. People with severe mental health conditions die prematurely as much as 2 decades early due to preventable physical conditions. Mental health and physical health are closely connected. Mental illness, such as depression and anxiety, affect people's ability to participate in a healthy promoting behavior. In turn, people with physical health, such as chronic disorder, can have a serious impact on mental health and decrease a person's ability to participate in a treatment and recovery. So, stigma towards mental health. Public stigma involves the negative or discriminatory attitudes that others have about mental illness. Self-stigma refers to the negative attitude, including internalized shame, that people with mental illness have about their own conditions. Institutional stigma is more systematic, involving policies for government and private organizations that intentionally or unintentionally limit opportunities for people with mental illness. Examples including lower funding for mental illness research or fewer mental health services relative to other healthcare. Many people with serious mental illness are challenged doubly. On one hand, they struggle with the symptoms and disabilities that result from disease. On the other, they are challenged by the stereotypes and prejudice that result from misconceptions about mental illness. As a result of both, people with mental illness are robbed of the opportunities that define a quality life, such as good jobs, safe housing, satisfactory health care, and affiliation with a diverse group of people. In this table, demonstrated the reaction that the general population has to people with mental illness. Self-stigma is a prejudice which people with mental illness turns against themselves. Both public and self-stigma may be understood in terms of 3 components, such as stereotypes, prejudice, and discrimination. Social psychologists view stereotypes as efficient social knowledge structures that are learned by most people of social group. They are efficient because people quickly generate impression and expectations of individuals who belong to those stereotype groups.
Hello, my name is Himani, and today I'm going to be talking about the problems across the World Bank regions and the significance for morbidity and mortality. Talking about the burden of mental health in low and middle income countries, although mental health is common throughout the world, the burden is high in low and middle income countries. South Asia has a higher burden of mental disorders compared globally. A study showed the burden of chronic mental illnesses in South Asian countries to be 14.2%, which was higher than that globally, which was 13.4%. Mental illnesses comprise of 11% of disability-adjusted life years and 27% of years lived with disability in Southeast Asia. In countries such as India, 3 to 4% of its population has been found to have mental health issues. The greater prevalence of mental illnesses in low and middle income countries is due to social factors such as changing lifestyle, growing urbanization, internal migration, and cultural factors where they may not seek help of a mental health professional. The prevalence of mental illnesses is increasing in the Middle East and North Africa regions, including Pakistan and Afghanistan. In these regions, depression comprised of 44.6% of the total burden from illness, which was followed by anxiety in 2013. Women are seen to be disproportionately affected in these regions. Strong association has been found between conflict and mental illness burden. However, there might be exceptions such as in Yemen, depression accounted for 622 diaries per 100,000 in 2013, which is lower than the global daily of 860. This contradiction may be due to people hesitating to get mental help during conflict or due to the lack of high quality data. It is estimated that by 2050 there will be a 130% increase in the burden of mental and substance use disorders in sub-Saharan Africa. This may be due to factors such as aging and growing population. Talking about the burden of mental illness in US, in 2019 it was found that 51.5 million US adults have a mental illness, which is 20.6% of US adults. And talking about the burden of mental illness among the females, it was 24.5%, and it was lower among the males, which was 16.3%. And in the different age group, it was 29.4% for the 18 and 25 years old, 25% for the 26 and 49 years old, and finally 14% for those above the age of 50. And the adults reporting two or more races had the highest burden of mental illness in US, which was 31.7%. A finding during the research regarding this hot topic mental health was that data regarding the burden of disease due to mental health across the World Bank regions is limited. This might be due to the issue of less reporting by the countries due to various factors such as lack of funding and stigma attached to mental illness in many countries. Stigma not only affects the people suffering from mental illness, but it also affects the family members. A study has shown greater stigmatization against people with mental illness in Asia compared to Western nations. People are hesitant to receive mental health services, and people with mental health issues are often perceived as being dangerous. Next, talking about the burden of suicide, more than 800,000 people die every year due to suicide. Globally, suicide rate is higher among males than females, which is 13.7 per 100,000 and 7.5 per 100,000 respectively. In 2016, more than 79% of deaths due to suicide occurred in the low and middle income countries. More than 52.1% of deaths occurred in people less than 45 years of age, and more than 90% of adolescents who died were from low and middle income countries. Although, as we mentioned before, that in 2016 more than 79% suicide deaths occurred in low and middle income countries, the age standardized suicide rate was found to be the highest in the high income countries of the World Bank region. Next, looking at this diagram, we can see that the experience of depression and anxiety is consistently highest among the poorest 20% across all the World Bank regions. And in this diagram, we can see the distribution of people who had a depressive disorder worldwide as of 2015 by WHO region. We can see that it is highest in the Southeast Asia region, which is 27%, followed by 21% in the Western Pacific region, 16% for the Eastern Mediterranean region, 15% in the region of the Americas, 12% in the European region, and finally 9% in the African region. Finally, looking at the prevalence of treated mental illness in this diagram, we can see that the prevalence of treated psychosis, bipolar disorder, and depression across the World Bank regions is highest in the high-income countries compared to low and lower middle-income countries. So we can say that we can see these variability which may be due to factors such as lack of health infrastructure, mental health professionals restricted to urban areas, and socio-cultural factors. Next, Victoria will talk about the parties and agencies involved with addressing mental health.
Hi, all. My name is Victoria, and I'll be discussing the parties and agencies involved with addressing mental health. We'll start off with what the World Health Organization is doing towards mental health. According to data from the Institute for Health Metrics and Evaluation, the HWO channeled $28.4 million in development assistance in just 2018. This is a big deal. So what this aid is used towards is it's spent on projects whose primary purpose is usually promoting mental health or preventing or treating mental and substance use disorders. So I'd like us to move on to the HWO's Global Plan of Action on Workers' Health and their Mental Health Action Plan. So the goal of this plan is to outline relevant principles, objectives, and implementation strategies to promote good mental health in the workplace. The HWO also produced a series called Promoting Workers' Health, which works hand in hand with another organization called the Wellcome Trust. And what the Wellcome Trust is, it's a charitable foundation that's basically focused on health research based in London. So they're an organization that helps improve mental health for everyone by trying to fund research, leading policies, advocacy programs, all that type of things, which includes building global partnerships. Also, the HWO also plans to work with the International Labor Organization to create new guidelines to address the actions required to prevent, manage, and overcome mental health conditions. So by now it should be clear that the HWO is putting in quite some work and effort. So the HWO is spearheading the Special Initiative for Mental Health, which aims to support access to quality and affordable community-based mental health for 100 million people in 12 countries. So if we look at the right of the screen, we can see the strategic action plans that they'll be used to kickstart this initiative. And they hope that by 2023, they're able to give access to 100 million people. So the first group of countries that will be included in this initiative include Paraguay, Ukraine, Zimbabwe, Jordan, Bangladesh, and the Philippines. When these 6 countries have been established, they'll move on to another 6, and then hopefully when they finished with the 12, they'll be able to move on to another 6 and they'll continue from there. The goal is for everyone to get the help that they need and deserve. So I'm sure by now we're all like clapping our hands for the HWO, but it doesn't end there. So they've also created various global guidelines about mental health and substance abuse, and they also host an online platform called Mind Bank. What Mind Bank is, it basically brings international resources together and national policies and laws covering mental health, substance abuse, disability, and things along those lines. Also, they brought about another initiative called the Quality Rights Initiative, which aims to promote the human rights of people with mental health conditions while improving their access to high quality services. So, the Quality Rights Toolkit provides countries with practical information and tools for assessing and improving quality and human rights standards in mental health and social care facilities. The toolkit is based on the United Nations Convention, the Rights of Persons with Disabilities, and is designed for use in low, middle, and high income countries. Basically, everyone would be able to use this. So, the HWO isn't the only organization we should be clapping for. The United Nations International Children's Emergency Fund, commonly known as UNICEF, is also doing a very, very good job at tackling the world's mental health crisis. Mental health and psychological support, which is abbreviated to MHPSS, is an institutional priority for UNICEF. It has actually been part of its core strategic plan for 2018 to 2021. So, this should tell us how important this mental health issue is to UNICEF. It also remains a very fundamental part of its core commitments for children in humanitarian action. UNICEF has co chaired the Interagency Standing Committee and the MHPSS reference group for over 6 years, and the goal is to support the implementation of key priorities for improving the response in emergency settings, especially in the field of mental health. Lastly, UNICEF is currently developing a data collection tool called Measurement of Mental Health Among Adolescents at the Population Level, and that will gather data on mental health in low and middle income countries. Another honorable organization that is helping in the fight towards mental health is the United Nations Population Fund, abbreviated UNFPA. UNFPA calls for mental health to be integrated into sexual and reproductive health policies, strategies, programs, services, statistics, training, and publications. Basically, they are a voice for the voices that have been silenced. They also work in emergency settings to provide psychological care for GBV survivors, which is the gender based violence survivors, and developed a minimum standard for prevention and response to assist these survivors in attaining access to good mental health care services. The UNFPA is also tackling this one country at a time.
My name is Janet Mgofwa. I will be presenting the criticism of global mental health. I will cover the historical context, the influence of cultural imperialism, racism, and prejudice, the subjectivity in diagnostic processes and wrongful labeling of individuals with mental illness, the lack of focus on real causes of mental illness, the lack of true partnerships and collaboration, and lastly, the suspicion surrounding the role of big pharma in global mental health. Psychiatry as a separate medical discipline started in the 19th century. Since then, European and American psychiatrists have pushed Western Eurocentric mental health models on non-Western cultures and people. In 1821, Kraepelin, a German psychiatrist, claimed that the people of Java rarely displayed signs of depression due to what he called psychic underdevelopment. This is because they did not fit his mold of what depression should look like. In 1851, Cartwright, an American physician, described drapetomania as a mental illness unique to slaves possessed by a desire to freedom to escape captivity. The stereotyping of our people due to their social status negates the fact that any human being in the position of the slaves would have been looking for any means necessary to escape. Global mental health is relatively new. It was established in 2007 with the goal of improving mental health services, especially in low and middle income countries where effective services are often scarce. The concerns about global mental health resemble concerns of the anti-psychiatric movement of the 1960s. These concerns include the subjectivity of diagnostic processes, the potential for harmful treatment like in electroconvulsive therapy, the inhumane treatment of the mentally ill individuals, such as involuntary confinement, institutionalization, isolation, and incarceration. The other criticism is that of classification of mental illness. Official psychiatric categories evolve, disappear, and reappear, reflecting both Western social and cultural medical thinking. For example, DSM-3, published in 1980, expanded homosexuality as a mental illness and replaced it with PTSD for the first time. Imagine all those non-Western countries who had adopted the same thinking about homosexuality being a mental illness, and now Western practitioners look at them as being primitive, even though it was based on earlier Eurocentric mental health models. It would be extraordinary if such classifications made sense to the great diversity of societies and situations worldwide. It is also argued that global mental health pays less attention to the real causes of social suffering, such as structural violence, war, poverty, and famine, but instead focuses on prescribing and providing medical solutions to non-medical problems. For example, social suffering may superficially appear like depression when it is in fact not a mental illness, but an expected reaction to social conditions. Global mental health movement is also criticized for lacking true partnerships and collaboration with non-Western countries and other disciplines of mental health. It has been seen as relegating decades of work in cross-cultural psychiatry and medical anthropology, work that seek qualitative understanding of local and indigenous concepts of mental distress and social determinants of mental health treatments, and healing practices. Western universities and NGOs send their people for short mission trips, internships, and study abroad programs that are seen as unidirectional and not very beneficial to the communities they intend to serve. There are no reciprocal programs for universities from the developing countries to travel to the West. There is suspicion about the role of Big Pharma in global mental health. Critics see Big Pharma as having a hand in the repackaging of social suffering as a medical problem to exploit potential new markets through mass medicalization of people in developing countries. The suspicion is enhanced by the fact that WHO's mental health gap program strongly recommends the use of psychotropic medications in developing countries. WHO is seen as if it is working in lockstep with Big Pharma. For global mental health to be effective, critics suggest new research that does not overemphasize predetermined Western biomedical notions of mental health as described in DSM. They also argue that you cannot compellingly claim universality of psychiatric categories as there are no straightforward biological causes of mental illness like in other conditions. They recommend that local concepts must be a starting point for the creation of valid instruments for screening or diagnosis of mental health problems.
Hello everyone, my name's Madison. I will be concluding this PowerPoint lecture presentation for you. So my last part here will be the 3 priority areas for action that involve around mental health. So the 3 priority areas for action that I thought would most benefit mental health would be the green space intervention, establishing universal health care coverage for mental health, and frontline workers' mental health from the strain of COVID-19 and any other future pandemics that might come across. So first that we're going to talk about is the green space intervention. This is an intervention that kind of involves, as it sounds, a green space. Unfortunately, there is a lot of lack of proper evidence for green space intervention, but there are some studies that did review it. These studies help review gaps for potential of usefulness. The World Health Organization in 2017 had initially supported the establishment and maintenance of urban green spaces, but it did kind of fall apart a little bit. So I do feel like it could be extremely beneficial for mental health. So as we're looking at green space for mental health, you have a wide range of green spaces. This can include gardens, woodlands, plots, parks, ponds, farms, and really any green space that you can find. In a recent study done in 2020, this identified 7 key elements from these green spaces that can improve one's mental health. First, you have escape, getting away. This is basically an immersion factor. You have a space to reflect. This helps you gain self-confidence. A space to enjoy and perform physical activity promotes your health and wellness, not just physically, but mentally. 4, you have self-efficacy. So this has new skills that can lead to increased self-esteem, pride, and confidence. 5th, having purpose. So for example, in a farm setting, you're taking care of something else. You have a task. Having success with this task could help lead to better mental health and prove to you that you can be successful in this, you can be successful in the rest of your daily-to-daily life. 6, you have your relationship with your facilitator. So this space, if you're having a hard time, say, in an office setting, in a more open setting, it makes it more non-judgmental, a more open, relaxed space. And last, it's a shared experience. Being outside helps social cohesion, and you have that peer support. There's people around you. You can keep your mind off of other things. Currently, $1.6 trillion is spent a year on mental health. Health systems still are not adequately responding to mental health. And because of global urbanization, it's reducing access to green spaces. Green spaces lead to less mental stress, less anxiety, and less depression. There's no reason why we can't globally urbanize as well as maintaining green spaces in our society. How do we promote mental health? Environmental factors, which can be biodiversity, air quality, noise. All of this comes from quiet green spaces. That's going to be your qualitative data. And your quantitative data would be tree canopy cover, nice weather. All of this promotes your mental health. Your personal factors, you can relive your childhood memories, value nature. Your social and community factors include interaction, gaining trust, cultural norms, access to just in general a greener, quieter space. There is a need for greater interdisciplinary action to promote better mental health and well-being. Now, our second priority action to discuss is going to be achieving universal health care coverage for mental health. Mental health is a leading contributor to the global burden of years lived with disability. Achieving cost-effective interventions for mental disorders is the highest priority. High-income countries have mood and anxiety disorders gap at 50%. Low-income countries gap exceeds 90%. Budget and stigma is hindering progress being made towards improving mental health and mental health treatment. There is a need for integration into primary health care, which could include nurses, community workers, or peers. The World Health Organization initiated a plan for mental health in 2019 and extends into 2023. This was with a hope to empower individuals to achieve the highest level of health. It ensures access for mental health to 12 priority countries and with hopes to reach 100 million people. This goal is hopefully to contribute to the Sustainable Development Goals that they have been trying to pursue, with an end goal to achieve coverage of severe mental health to 50% and reduce suicide mortality by 15%. The third priority action is going to be frontline workers' mental health from stress of COVID-19. There are many negative consequences that have stemmed from the COVID-19, and mental health workers have been seen to be hit the most. They have a lot of stress exposure and fear of infecting themselves and their loved ones. There is a lot of lack of support and communication. There's no coping strategies as COVID-19 is proving to be something that is not really been seen to this kind of degree. We were very unprepared and healthcare workers were hit the worst. They had inadequate training and it put more strain on providers than what they usually were faced with. They were faced with many difficult decisions, prioritizing, so they had to prioritize who was getting what treatment. For example, who was getting the vent, who was getting your care. Another added stressor that these care workers faced were basically when their patients died, they became the family members. The family members were unable to be with the patient. So ultimately, the nurse, the doctor, whatever kind of healthcare provider became that family, and that caused an extreme emotional toll that no one truly expected. A survey was conducted in 2020 by Johnson & Johnson. I'm not going to read to you all these statistics here, but some of the big ones I would like to highlight. 93% of healthcare workers were experiencing stress, 86 reported anxiety, 77 frustration, 76 with exhaustion and burnout, and 75% just said they were overwhelmed. A lot of the higher statistics here would be fatigue, especially compassion fatigue. I like to point out 55% were questioning their career path, with a 40% feeling that they weren't being supported, 45% were even less likely to have emotional support. A lot of healthcare providers also felt that their children and family members were being affected by just their emotional state as well. In conclusion, I just would like to remind everybody that mental health does have that high level of prevalence. Suicide is the leading cause of death between 15 to 29-year-olds. There is unfortunately too much stigma around mental health, and that ideology has to be changed in order to get the proper treatment, resources, and funding to assist mental health. There's not a whole lot of data and studies, as many of us has noted throughout this PowerPoint. So more data is necessary in order to improve everyone's ultimate well-being. We would like to thank you very much for watching our PowerPoint presentation. And from all of us, if you or if anyone you know is in need for mental health or is currently in crisis, please reach out for assistance. Thank you.